being Dean's Forum, I'm going to turn things over to our Dean Learman for introductions of Dr. Chang and Pierluissi.
Thank you, Dr. Wicker. It is truly a joy to introduce our two speakers for today's Dean's Forum. The full name of Dean's Forum is Dean's Forum on Hot Topics and Challenges in Medical Education, perfect for the topic of today. So I will try to do justice to these two wonderful scholars who are joining us today. Dr. Anna Chang is professor of medicine in the UCSF Division of Geriatrics, Department of Medicine. She's an educator, mentor, clinician, and leader, nuclear scientist, and musician. No, I'm just kidding. Those last two I made those up. Unless they're true, maybe they're true. She received her MD degree at St. Louis University, completed the residency program in internal medicine at UC Davis, and a fellowship in geriatric medicine at UC San Francisco, where she also completed the UCSF Teaching Scholars Program and Medical Education Research Fellowship. Dr. Chang is board certified in geriatric medicine and hospice and palliative medicine. She's Associate Chief for Education in the Division of Geriatrics and Director of the Tideswell and American Geriatric Society National Emerging Leaders in Aging Program. She served as the Gold-Headed Cane Endowed Education Chair, ask her all about that, where the name comes from, in internal medicine at UCSF, and as a member of the National Board of Medical Examiners. Although Dr. Chang and I did not exactly overlap when I was at UCSF, she is someone whose career I've been following from afar. One of her most important roles is to direct the UCSF School of Medicine's Bridges Curriculum Clinical Microsystems Clerkship. The clerkship is one of the most innovative aspects of the health system science curriculum at UCSF. It is a longitudinal integrated experience for first and second year students in which they learn clinical skills as well as skills for understanding and improving clinical microsystems with expert preceptors. So welcome, Dr. Chang. Dr. Edgar Pierluissi is a professor of clinical medicine at UCSF. He is medical director of the Acute Care for Elders unit at the Zuckerberg San Francisco General Hospital. He has cared for vulnerable populations his entire career and is committed to healthcare quality improvement. He merged these interests as the founding medical director of the Acute Care for Elders unit. And since opening in February 2007 and expanding 2 years later, the unit now cares for over 1,000 patients a year, which is tremendous. Dr. Pierluissi received his MD degree from Harvard Medical School after completing his training in internal medicine at UCSF and at the Veterans Affairs, where he did a National Quality Scholars Fellowship. He worked for the County of San Mateo, our former home, for 14 years as a staff physician, medical director of the North County Health Center, and a VP for quality improvement. He joined the faculty at UCSF Division of Geriatrics in 2006 and San Francisco General's Division of Hospital Medicine in 2008. And of course, works with Dr. Chang and this wonderful initiative at UCSF with the Bridges curriculum. Welcome, Dr. Pierluissi. So to both of you, I'm just so glad that we had the opportunity to meet a few weeks ago or months ago, was it, in advance of your visit, and for me to reconnect with an institution that helped me develop in the first 14 years of my career in academic medicine. I want to thank you both for being here with us in person, for meeting with our curriculum leaders and with our Teach Health System Science cohort, and for the Sunrise Dean's Forum this morning, which is very early your time. So please, everyone, please join me in a warm election day welcome for Drs. Chang and Pierluissi.
Dean Lehman, thank you so much for this invitation. The hospitality, the warmth, the generosity that we've experienced from your team here, from the faculty we've met, has just been really, really terrific. We've learned so much. This is such a beautiful part of the country. So I want to thank you again for this invitation. It's been really special. So we're going to talk today about health system science training for physicians in training. Our roadmap for today is to state a shared vision for incorporating health system science as a third pillar in medical education. Anna will then discuss the current literature pertinent to our approach to integrating health system science in medical education. And then we'll describe some of our program outcomes and some success factors that we think were important in integrating learners and clinicians in learning health systems. I think I can take this off. Excuse me. Okay. All right. So we're going to talk about the rationale. So for many of you, you've heard this story before, but I still think it's important to articulate it and to place it in the context of about 10 or 15 years ago, where leaders like Jed and Catherine Lucy and others were the first to pose the question that we're going to get to. The problem, as they saw it at the time, is that we have a problem in the U.S. healthcare system. Despite being the costliest in the world, quality, safety, disparity, patient and provider experiences were lower than expected. And here you see some key publications. This was in 1999, the To Err is Human, which highlighted the problem we have in American medicine with regards to patient safety. Later, we saw Crossing the Quality Chasm, which highlighted the problems we have in quality in this country, and then the Unequal Treatment, which highlighted the problems we have in disparities. I'm going to go through a few data points just to make these points clear. Before I do, I will say this. I could talk about a ton of data generated from the late 1960s that John Wenberg showed us about variations in healthcare, which raised questions about not only healthcare resource utilization, but quality and how it varied from region to region without any clear underlying rationale for why that is the case. Later, there's a lot of work from the Rand Corporation, Bob Brook and others, Elizabeth McGlynn, show that in fact, when you just look at quality of care in the United States, whether it's primary care or in a hospital, the results were not what we had hoped for. That data, I think, is important, and it helped to, I think, generate some of the discussions that people like Pierluissi and others were having. But I'm going to focus on one paper only because what it did is it takes the U.S. and puts it in the context of the rest of the world in terms of quality as well as cost. And so we're gonna move there. This is a paper that Ashish Jha published in 2018. And he took OECD data that looks that has results from countries all over the world, in particular developed countries, and you can ask about outcomes related to patient care and compare them to each other. And so here you see different countries: Netherlands, Australia, France, Germany, and here's the United States. And what we're going to do is compare them to each other. And I'm going to do this for a variety of domains. So the first is on access and the ability to get a same or next day appointment. And here, half the respondents in the United States were able to get same day or next day appointments compared to other countries. We were sort of in the middle of the pack. If you look at clinical outcomes here, this is 30-day stroke mortality per 1,000 patients. Ignore this thing up here because I'll go over where they rank. But if you look at 30-day stroke mortality per 1,000 patients, the US is doing pretty well. It's at 4.2 compared to, say, Canada or Sweden, down around 10. If you look at 30-day mortality per 1,000 patients within acute MI, again, the US is doing very well. So the nice thing about this paper is that instead of highlighting areas where the United States is doing poorly, they had a whole range of metrics, and you can see there are pockets of excellence in the United States in terms of healthcare here. Now, this is in terms of clinical outcomes for stroke mortality and acute MI. If you look at avoidable hospitalizations, again, avoid this part here. Here, these are the higher the number, the worse it is. So diabetes hospitalizations as a ratio of people with diabetes, US is kind of on the high end of things, and it's the highest in terms of asthma hospitalizations as a ratio of people with asthma. The idea here is that we're having trouble in the primary care setting preventing hospitalizations. I'm just going to spend a little bit of time here. You all are familiar with this data. In terms of life expectancy, whether life expectancy, the total population at birth, or health adjusted life expectancy, the US is the worst among these countries. And in addition, we have problems with healthcare disparity. So since 2003, the Agency for Healthcare Quality and Research has produced the National Healthcare Quality Report. But starting in 2014, they've merged the Healthcare Disparities Report with the National Healthcare Quality Report. And I'm going to show you data for 2014 and 2016. Just going to focus over here on Black population versus white population. And what they do is they have a whole battery of quality measures. In this case, measures in this case, there are, well, we'll go through each of these, but it's about 150 or so quality measures or more. And what they do, and these include things like vaccination rates, control of hypertension, control of diabetes, getting your colonoscopies and mammograms and so on. And if you look at Blacks versus whites here, in 74 of the measures, Black patients were worse off in terms of these quality measures than whites. About in 83 of the measures, they were about the same, and in 19, they were better. And while this number has gotten smaller over the years, it just points out where we started, which was at a pretty bad place, because this is still, to my mind, unconscionable. So this is a problem, again, in addition to the quality metrics we saw embedded in all that, we also have a huge problem with disparities in healthcare, in health and healthcare. No surprise when you ask patients, how are we doing as far as this, whether our healthcare system is working well, you see that the United States is almost at the very bottom here, compared to the countries where we do have data. There was another question that went right below this. I didn't show this here, but the question was, should we blow up the system and redesign it? And of course, people from the United States, that we were the highest ranking country in answer to that question. Now, you might say, well, you get what you pay for. And so the question is, what are we spending on healthcare? And if we were spending a lot less than other countries, you might say, okay, this is about what you'd expect. But you all know that, of course, we're not. This is a chart of developed countries and their healthcare spending per capita. And here we're up around 12,500 for the United States. The next nearest country down there is Germany, and that's at about 10,000. And so we're spending way more than other countries here. And as a percentage of GDP, it's actually even worse. So we spent about 20% of healthcare in 2020. About 20% was spent of our GDP was spent on healthcare, compared to Germany, the next country, which is about 13%. So we're spending a lot, and we're not getting as much as we probably ought to in return. Which led to which reminds me of this quote that as soon as I saw this has stuck with me. I've used this in a lot of talks when I've talked about rationale for health system science. I'm just going to read it. If we do nothing to slow these skyrocketing costs, and at this point, you know, if you look at GDP spending, healthcare as a proportion of GDP, from about 2010 to about 2017, it was about the same. It was about 17%, getting up to 18. Early when this quote was done, it had been climbing from 13, 14, 15%. So if we do nothing to slow these skyrocketing costs, we'll eventually be spending more on Medicare and Medicaid than every other government program combined. Every other government program combined. And then the conclusion being put simply, our healthcare problem is our deficit problem. Nothing else even comes close. This is from Barack Obama in 2009. So what does this have to do with medical education? So this is the reframe that leaders like Chad and Pierluissi and others asked, because up until their innovation, their innovative thinking about this, nobody was asking this question. They just weren't. But they asked the question and then developed a body of work that where some of these papers are listed here, but a body of work to develop a consensus among medical educators over the last 10 or 15 years, that in fact, it has a lot to do with medical education. And the question they asked that was novel was, well, we've seen what happens when the healthcare system, when medical education does not address these issues. That is, when we don't prepare medical students to become physician leaders who care about improving the systems that they work in, who care about value. When we don't do that, we get the results we get. So it sort of reminds us of the Don Berwick phrase that every system is perfectly designed to get the results it gets, and we were getting those results, and they were not satisfactory. So this body of research helped to make the case that, in fact, to the degree that our not addressing this is contributing to the problem, we have a responsibility to attend to that. And your dean is one of those leaders who sees this. When we spoke about this earlier, his quote, which I thought was terrific: we want to graduate leaders who are not running away from the fire. And I think the data that I showed is, I think you could describe it as a fire, but running towards it with a water hose. Our learners will become system citizens who improve health and healthcare. That's the goal. So the hypothesis then, to summarize, is that by incorporating health system science into medical education education can be a part of the solution for complex healthcare delivery problems and improve all the things that we talked about before: disparities, address increasing complexity with social determinants of health, improve quality of care, healthcare value, and interprofessional teamwork as a stated goal of this education. I bring that up in regard to patient complexity. It's clear when you look at care models that address, for example, the Medi-Medi population, they are team-based as a rule. You cannot achieve the goals you want to have individually. They have to be done as a team, and physicians need to be part of those teams. And in addition, physician career satisfaction. We're not going to really talk about this too much. We can talk about it anecdotally, maybe in the question and answer. But this is an important issue. When I talk to healthcare leaders in the Bay Area, this is close to number one on their list right now of in their concerns. How do I prevent physician burnout? So I'm going to stop there. And Anna will talk about the underlying theoretical framework that helped to drive what it is we did at UCSF.
Thank you very much. I'll just do a quick check on sound. It sounds like you can hear me. Yes? Wonderful. Thank you so much. I will start by echoing Edgar and thanking Dean Bierman. It's been an incredible time here. You have wonderful people, and we've really learned a lot and benefited a lot from this trip. So thank you all for your generosity. This next section is just to give one example. It isn't the only way to do things. It is the way that we chose to start trying to make a difference. And we're here to learn from you in all the ways that you're also already making a difference. In our objectives, this next section, we will go over some of the current literature that underlie the way we designed our curriculum. This was our million-dollar question when we started, which is, how do physicians in training, and these are our students standing by the San Francisco VA, how do they arrive at the understanding that health system science is a part of their professional identity? Many of us went through medical education without this being a part of our training. We came in as lay people and exited as physicians, and some magic happened in the middle, and we don't really exactly know what happened. We thought that there must be a better way to think about how you might design a program, an educational program, so that it's a bit more intentional than let's cross our fingers. So, in other words, what we asked was the question, how do you get people to the point where they think, act, and feel like physicians? Oops, excuse me. So our approach at UCSF is, we thought if we design the learning environment that allowed for communities of practice to shape learners' professional identities, that we might be able to move the needle a little bit closer. So in other words, our approach is based on these three concepts from the medical education literature. One is the learning environment. The second is communities of practice. And the third is professional identity formation. And we'll go through them one at a time. This paper is lovely. It describes the learning environment with a conceptual framework that helps us figure out the areas that we need to attend to, either when we're designing a new program or problem solving something that isn't going well in an existing program. So I'll just go through some of these from the top left around, and these will all make sense to us as we hear them. The first is the personal domain. Obviously, the learning environment is around the learner. The learner's identity formation depends on everything else here. And we are saying that it matters how we shape their personal growth, their goals, their engagement, emerging autonomy. How do we help them be resilient and be well in the process? Thank you so much. And then going from the personal out a bit further, we can see that there's a social component to the learning environment. The people who surround our learners, that for us would be other learners, physician educators, interprofessional clinicians, and others in the area. So we believe, and the literature shows, that learning happens in scaffolded relationships with others. Learning happens when you become a member of a community, and that these interactions when you're teaching and learning and providing patient care are what teaches you what it's like to enter this profession. Going more broadly into the organization, all of us practice and work and learn and teach within organizations, medical education and also healthcare. And so what we said was nothing we design will be divorced from the organizations within which we exist. So the organizational rules, practices, culture, policies are essentially the water that we swim in, and we want our learners to be there as well. And then finally, physical and virtual spaces. When we started thinking about a new program, I don't think we realized we had a lot of lesson learned. But I don't think we realized how important it is to have the learners be physically, virtually there. Because what happens when you are situated there is you're a part of the interactions that happen around you, even if they are not directing teaching at you, you're learning by being in the environment. So these are the things that drove the design for us. And thank you. That's perfect. I am really intrigued by this concept and I wanted to bring it to you. This idea that the learning environment that we design can facilitate transformative learning. Transformative learning is an outcome of medical education that we want to have. We want them to come in and go out as different people. So we know that transformative learning opportunities influence someone's professional identity. We want to design learning programs so that there are opportunities for this kind of learning. What we know is that they're best facilitated through immersion in the workplace. And what happens when you immerse in the workplace is you become faced with real, complex, and unfamiliar contexts that challenge you. These are described as disorienting dilemmas, but they challenge your way of thinking and they change the learner's values, attitudes, beliefs, and behaviors. These are all the things that we want to have happen when we put our learners in the workplace. We'll connect this to the second concept from the literature that's important to us when we built our program, and that's communities of practice. Just for a definition, this is all going to make sense to us. A community of practice is a social network that shares overlapping knowledge, beliefs, values, history, and experiences on a shared practice, which in our case is the practice of medicine. What we know happens when you put people in communities of practice is that they increase for really everyone in the community, learners and educators alike, a sense of collective identity and shared purpose. Everyone gains knowledge and skills. People are more satisfied and they're more productive. This next concept connects communities of practice to expertise. I'm going to read this quote because this we believe to be true. That expertise is not simply a property that passes from teacher to learner, but a dynamic commodity that resides within communities of practice. So learning, according to this theory, is a process of absorbing and being absorbed into the culture of such community. So this is, I think, to say that we saw our jobs not as just transmitting knowledge and skills or helping learners achieve confidence, but we're helping them embrace a different professional identity that includes health system science. So the next few slides talk a little bit about what we did. Again, it's just one example with one learner level, at one institution, but we learned a lot in doing this and we wanted to share this with you for discussion. In 2012, our new Vice Dean for Education, Pierluissi, came in with a vision to say that we are going to overhaul our educational programs and train physicians to be effective in the 21st century. And we did a roughly 3-4 year design process and launched the Clinical Microsystems Clerkship in 2016. This is the required longitudinal clinical skills course that integrates clinical skills and health system science for students from the day they enter medical school until the day they go to clerkships. Our design principle here was that we were not going to do anything just in the education setting that made no sense in the clinical setting. If we want to train physicians to enter the clinical setting effectively, we're going to start training them there. So important to our design was a strong partnership between medical education and our health systems. Obviously, that existed before we started, often in GME, a little bit in the clerkships, not so much in early medical student education. We went to our 3 affiliated health systems, academic, safety net county, and also REA, and said, how about embracing 150 first-year medical students? There was a little bit of skepticism. We're very convincing. This happened. So what we have are a number of learning communities that happen across a whole lot of different clinical settings that include medical students, faculty, clinicians, everyone looking at the health system's true north. That's the picture that's on the right, so that we align everything that we do with what's important to our health systems. So in order to do that, we had to open up space in the curriculum. So we opened up 1 day per instructional week in the pre-clerkship years, so that roughly half of the day is devoted to clinical skills training and roughly half of the day is devoted to health systems improvement. After we opened up space in the curriculum, we hired faculty. We had approximately 55 educators engaged in this process from all different clinical sites and all different departments. We brought them together to do fairly intense and sustained faculty development so that they would have a shared set of knowledge and skills. They would have an understanding of our new curriculum so they could become ambassadors to our students. We have the same approach to learners when it comes to problem solving. And faculty who are clinicians at a particular health system also share that context, the culture of that health system, and also the way that they interact with the interprofessional teams. So what happens over time is that the faculty have these sets of skills, knowledge and skills that allow them to teach flexibly over time because we're a longitudinal curriculum. And this also helps them individualize to each student group. Then we added the students into the learning communities. Again, the educators are physicians and interprofessional clinicians. What we learned is that the students and faculty both benefit from being in a community. The faculty learn from being in the community and our students as well. Most of our educators report that health systems learning happened regardless of what happened in the student's actual project. And so each student faculty group became engaged in a health systems improvement project aligned with the health system priorities. And the project goes on for the entire year, first year and second year. And sometimes they go beautifully and sometimes there are unanticipated barriers. Regardless, the learning outcomes are the same. So this is just to say that as we designed something new, we thought we got to figure out if it works, and this is how we were going to figure out, at least at a local level, if it works. We use the Kirkpatrick model of evaluation with the 4 levels, and wherever you see in subsequent slides a picture of this pyramid, it's a slide that shows some of our outcomes. For example, our first Kirkpatrick level 1 outcome, the first thing that we asked was first and second year students, do you like what we're doing? And on a scale of 1 to 5, our early students, even before moving on, realized that they were experiencing a course that was of high quality and that was of value to them in their development as a physician. The second slide has a lot of things on it, but this is just to say that we assess knowledge and skills with some standardized assessments. So for clinical skills, we had standardized patient assessments. For interprofessional collaboration, we had clinicians interact with our students, get feedback on communication and collaborative skills. We assess knowledge with health systems improvement with the QI-CAT, which is a validated tool that we revised. And then also for skills, the students submitted based on the lean A3 format that our health systems were using, project progress updates throughout the course of the pre-collection years that then we looked at and assessed and gave feedback. The summary here is they did fine. What we thought, what we worried about was when you change something, something's gonna fall apart. They probably didn't, and things did okay. So we're continuing to cross our fingers and hope that we're moving in the right direction. So a recap of where we've been, we've discussed the learning environment, communities of practice as 2 out of the 3 concepts we use. And the final concept is professional identity formation. Professional identity formation is defined as the process through which learners are transformed from members of the lay public into skilled professionals. What we know from the literature is that the most powerful factors having an impact include role models and mentors and experiential learning. These are some of the things we intentionally built into our programs. And our hope is that this represents progression from legitimate peripheral participation when they come in as novices to full participation in medicine's community of practice when they leave us as physicians. So can it work? This brings us back to Dean Lehrman's vision and also a challenge that we share. Can we design educational programs to graduate system citizens who improve health and healthcare? Or in other words, can we train physicians to have health system science as a part of their professional identity? We think yes, and we'd love to hear your thoughts. So the next section, Edgar will come back and share with you some of our outcomes and also our success factors.
Thank you. All right, so we're gonna describe again, as Anna was saying, some program outcomes and some factors that we think were important in the success of integrating learners and clinicians in learning health systems. I'm going to start by just summarizing what we did sort of at a high level. Over the last 6 years, we've had almost 290 improvement projects. They are in all clinical departments. We have surgery, anesthesia, radiology, you see there, but including dermatology, interventional radiology. They took place in clinics, in the hospital, in the OR, in the PACU, wherever clinical activity is happening. We have projects that were representative for that area. We worked with all interprofessional clinicians. I have listed there psychology, social work, pharmacy for sure, nursing, social work, physical therapists, occupational therapists. All of the interprofessionals we work with have participated in these student projects. And they were at all the healthcare systems as well, our academic, county, and VA. And I'm gonna, and we'll go over some of these projects, but they really did affect disparities, quality, safety, value, and patient experience. Here's just a listing of some. I'm just going to highlight 2 or 3 of these because I think they raise important principles. The very first one is reducing disparities in hypertension control for Black patients. This is at the University Primary Care Clinic, where they showed a disparity in control of hypertension for Black patients. The students got involved. They did a deep dive, mostly interviewing patients themselves about their lives, some of the issues that were surrounding their taking of their medicines and so on, perceptions about healthcare, the trust that they have in the healthcare system. And through their conversations and then a plan to intervene, they were able to increase percentage of patients with at-goal blood pressures by 38%. So we're very excited about that. One of the things we learned in general, we talked about this earlier with Jed, is that students were very motivated to work in the area of healthcare disparities. So that's an area where students are going to be self-motivated to make change. The other one, improving safety of opiate use after minimally invasive surgery. This was in laparoscopic gynecologic oncology surgery. The university as a whole identified opiate prescribing as a problem. And we have had probably 8 or 9 projects at least in the outpatient setting, in the inpatient setting, in this setting, in other surgical settings, focused on reducing opiate use. Many of those have been successful. I just want to talk about this one here. Again, this is a group of students who then interviewed providers, talked about their practice pattern, interviewed patients and their expectations around opiate prescribing, and then talked with our folks in IT as well, made some changes there, and were able to decrease prescriptions for discharge opiates by 30%. There's a couple of things about this project that's really nice. One, it does align with a higher organizational goal. Two, they hardwired these changes in working with by making these changes part of the EHR. And three, this is a project that's been picked up year after year. So some projects the students do their work for a year, and when they leave, while the group continues to do the work, there aren't students involved with that project. That happens. In this case, students were assigned to this project probably for 4 out of the last 6 years. And every single year, they've made about a 30% reduction in prescribing opiates, which again talks to massive overprescribing, which was a problem. And they've done the good work of using balancing measures to make sure that patients' pain levels were not worsening, and they weren't. Patients' pain levels were actually the same level of control before all this prescribing as it was after we reduced all this prescribing. So I thought that's a nice project. I'll talk about one other one. Here, obstetrics, again, improving safety of vaginal and cesarean obstetric hemorrhage. This is a project where the students linked with a statewide collaborative to introduce the measurement of quantitative blood loss, which helps to actually save lives, reduce maternal mortality. And we weren't doing it at SFGH, and here they were able to go from not doing it to a high rate of uptake in 84% of deliveries. And so this was a case where the students could see the role of physician advocates at the state level to make this a statewide collaborative, and then work locally to make change. When we assessed questions that we thought got to professional identity, we were encouraged by these results. So we asked now graduating MS4s whether they believe that clinical skills and health systems knowledge are both important to patient experience and clinical outcomes, and the majority said yes. This is at a rating of 1 to 5. And the other was a physician needs to have both clinical skills and health systems knowledge to be successful. And again, we were encouraged by these results, that our students left feeling like this is a physician does need to have this to be successful. Here's some quotes that we took from a wonderful paper that looks at the formation of professional identity in medical school. These are from UCSF students, where the first says, at the end of my career, I'll be in a position where the system is still not perfect and still has several holes in it. But hopefully I will look back and see patches that I've made along the way that would be something I'd be proud of. And the other I like is a very pragmatic perspective. Understanding the system is definitely important, in the same way that if you're a plumber, you should have a good understanding of the pipes that are not within the house itself. And so you want to look in the walls, you want to see what's underneath there. We tried to get at this question of identity around the work that we were doing in another way, and that was to look at whether or not students listed this work that they had done in their residency application CV, and most did, whether or not they had disseminated this work in one form or another during their time there, and about half had disseminated this work. And about a third reported that they discussed the work that they had done in the CMC Health Systems Improvement Project in their residency statement or interview. And I will say, in addition, we made this part of their dean's letter. So there's a separate paragraph in the dean's letter that highlights the work they did as part of a team, what problem they were working on, how much headway they made towards that problem, and some of the things that they learned, which we thought was important. Here's another quote: quality improvement is always a goal when it comes to patient care in residency. I will likely see how I can use my power and experience to change parts of the system. We're going to take a little bit of a digression here to talk about how you might do this in the residency setting. Now, I run something called the Health Systems Leadership Pathway that's for residents and fellows, mostly medicine residents, but it includes pediatric residents, family medicine residents. We've had some ENT, some anesthesia residents as well. And what we do here is to focus on healthcare quality improvement and healthcare policy. And we alternate 1 year with one focus, another year with another focus. We focus on development of personal leadership skills and have And then we go deep into a project. And so I want to talk a little bit about the projects to see what we're doing at the GME level is exactly the same thing that we're doing at the UME level. Just as we over the last 10 years, we've had about 125 residents and fellows do this pathway. Many went on to become chief residents and lead healthcare innovations and be leaders in startup companies in the Bay Area. And to give you some idea of the kind of involvement, I just want to talk about one of these projects. Here, the residents we have clients. We see the people we work with as clients. And the client this year was the Office for Population Health and Accountable Care at UCSF, who had a question about whether or not they should invest in home-based primary care as part of their ACO activities. We identified 10 academic health medical centers that we're doing this already. We learned from them. We took their learnings, made a set of recommendations to UCSF. They, including which positions to actually hire into to help them be successful. We then, the residents then presented their findings to the CEO and the leadership of UCSF Hospital, and they accepted those recommendations and invested $1.8 million to help expand their home-based primary care, which they thought would help them in the end have savings, financial savings. So this was a case where the residents work directly with the client. The client has a real world problem that needs to get solved in the next 9 to 12 months. And then the residents help to make, help that client think about that problem. And then the client can make their own decisions about what they're going to do. And we've done this in other areas as well. So what are some of the success factors? I'm going to first give some success factors that link to this idea of professional identity. And gets back to the question that Anna posed earlier about whether involving first-year medical students in this can affect professional identity. We think that the data we have is supportive of that notion, and we think some of the factors that underlie that is, one, to be explicit about including health system science competency as a professional, as a core competency for physicians. Two is to embrace communities of practice. The idea here is that when medical students are embedded in people who are actually doing the work, they will see that this really is part of their day-to-day work. It's part of their identity. We felt that if you made up experiences for them, that just wouldn't be the same, and they would see through anything that really truly wasn't authentic. So we tried to create these authentic roles both for the students and the work that they were embedded in. The authenticity relates to this engaging learners. The idea here is that the students had to have a real role on the team. The team relied on them. They counted on them to do work. If they didn't, the team suffered. They saw that, and it mattered. So we wanted to have them feel like they were contributing in a real way. We had to provide a faculty development, and as I said earlier, you can't provide enough faculty development. You have to give as much as your faculty are asking for. And then there are going to be domains that they will discover later on that are important that you want to think about beforehand and try to address if you can. I think that's important. And the last is assessing educational outcomes. We tried to do that wherever we could. Funding was limited for this, but we did that to the best we could. And you've seen some of the outcomes there. With regards to the health systems in medical education, there are a few things that I think also mattered. One is integrating learning with integrating learning about patients and systems. So Anna pointed out that we did this all in the same day. Students got the message that I'm learning how to be a doctor for individuals and I'm learning how to be a doctor for health systems, and that was explicit. We invited learners to join efforts aligned with health system priorities, which again, Anna pointed that out in the beginning. The link to the mission, vision, values of the organization really did matter. We engaged stakeholders, including health systems leaders, and we did this early on to let them know that we really did want to have our students helping them succeed. So we wanted to find out what were their pain points and how is it that our students can help them address those. 4 is really important, to show gratitude to clinical teams that engage with learners, in particular, those QI leads who are not getting paid to do this work. It's very important to let them know that you respect the work they're doing and to show gratitude. And we did that in a variety of ways that we can talk about later if you like. And then the last was to showcase and celebrate successes. So we created a symposium that was high level. All the deans were invited. The department chairs were all invited. The staff that were engaged, working alongside with the medical students were all invited to share. And what we did at those symposium is we highlighted 4 projects that we thought were particularly noteworthy. We trained the students to give an effective presentation over 5 minutes for each project. And then we celebrated successes. This was really, really important, I think, for a variety of reasons, but it was a place where everybody could come together and feel the win-win of the work that the students were doing. So in summary, we do believe that education can integrate health system science as a contributor to the solution to these complex healthcare problems that we talked about in the beginning, that educators can design learning environments and communities of practice for workplace learning aligned with the health system needs, and that health system science and clinical skills can be incorporated into the professional identity of physicians in training. I want to give a huge shout out to this UCSF Clinical Microsystems Clerkship team. As I said earlier, I've done a lot of work that's been very gratifying in the area of quality improvement throughout my career. I have never worked with a team that is as competent, as hardworking, as creative as this team, which is a testament to Anna because she built this team. And so I just want to say thank you to that team. It's a real pleasure to work with them. And so we'll stop here and take questions.
Thank you so much. That was fabulous.